So hello friends, welcome to my new video. So today's topic for discussion is RAPD, that is known as relative afferent pupillary defect. Okay, so from this video you will get to know that how to test this RAPD, and also you are going to learn about the pupillary pathway and different types of RAPD grading that are also done in our day-to-day OPD practice. Okay, so let's start. So RAPD is a condition in which pupil respond differently to light stimulus shown in one eye at a time due to retinal or optic nerve disease that occur in front of the lateral geniculate body. Okay, so before going to the discussion on RAPD, first of all we need to know about the basic thing about pupillary pathway. So this is a very ideal picture which is showing the normal pupillary pathway. Here if I shine the light in this left eye, then this light will go through the cornea lens and reach to retina. Okay, so from retinal ganglion cell the pupillary pathway actually start, and here from retina the pupillary fibers go to the optic nerve and then reach to optic chiasm, and it go through the optic tract, and before reaching to the lateral geniculate body it come out and reach to pretectile nucleus, and this pretectile nucleus actually reach to dorsal midbrain where it reach to the Edinger Westpol nucleus, and from this Edinger Westpol nucleus this pupillary fiber reach to third cranial nerve 3, and this cranial nerve 3 reach to ciliary ganglion, and this ciliary ganglion actually divide into two parts where some amount of nerve fibers are go to the ciliary body and some go to the iris. Okay, so this is the normal pupillary pathway. So here if I shine the light in this eye, then the pupillary response will travel through this direction and again come to the other eye. So this is called as efferent pathway and this is called as efferent pathway. Okay, so pupillary pathway are two types, efferent pathway and efferent pathway. Okay, so this is the flowchart of efferent pathway. Here it starts from the rod cone cell, that is the retinal ganglion cells, and then it travel through the optic nerve, then reach to optic chiasm, and after that pretectile nucleus and Edinger Westpol nucleus. So this is the flowchart of efferent pathway. Okay, so efferent pathway means direct, that is the pupillary response going towards the brain, that is called as efferent, and efferent means the pupillary response are going away from the brain. Okay, so this is how you will remember that pupillary response are going towards the brain, that is called as efferent, and the response that is coming back opposite to the direction of the brain, that is called as efferent pathway. Okay, so this is the pathway, efferent pathway. So axons of Edinger Westpol nucleus extend to third nerve and it cross to the brainstem and then divide into two parts. Okay, so some nerve fibers go to ciliary body and some go to the iris. Okay, so what is relative efferent pupillary defect? So relative efferent pupillary defect means the defect is present in the efferent pathway, and we can detect it by looking at the other eye also, and also comparing the constriction and dilation of the pupil. Okay, so here in this picture you can see that if I shine the light in the right eye, then left eye also constrict. That means this is the efferent pathway, and due to the efferent pathway this is also constrict. Okay, so here if I shine the light rays and the pupillary response go to the optic nerve, chiasma, optic tract, pretectile nucleus, Edinger Westpol nucleus. So this is the efferent pathway. So it's and the response that we get in the other eye due to the efferent pathway, that is called as consensual response. So this is the direct response and this is the consensual response. Okay, so here if we shine the light on the right eye, then this is the direct response due to that pupil constrict, that is the direct response, and the other eye due to the efferent pathway it also constrict. So this is due to the consensual response. Okay, now if I shine the light on the left eye, then here in direct response we will see that here constriction of the pupil is seen, and due to the consensual response the other eye will also constrict. Okay, now again if I shine the light in the right eye, then due to the direct response this eye will constrict, and due to consensual this eye will also constrict, and when I remove the torchlight then both pupil will dilate. That means the patient is having normal pupillary pathway, there is no defect, that means there is no relative efferent pupillary defect. Okay, now let's see this example. Here if I shine the light in the right eye, then the other eye is also reacting. That means direct response is present in the right eye and consensual intact in the left eye. But if I shine the light in the left eye, then this pupil is not reacting, then it is actually dilating. That means The defect is present in the efferent pathway, not in the efferent pathway. So this is why direct response is not present, and due to that thing, that this eye is not actually constricting or dilating, pupillary response is not going to this efferent pathway due to optic neuropathy. So this eye is also not showing, and it is also dilating because it is not getting any pupillary response from the other eye. Okay, now if I again shine the light in the right eye, then the direct response is present in the right eye, and left eye, due to the consensual response, it actually constricts. Okay, so again I am telling you, because you all are getting confused, that suppose the optic neuropathy present in this eye, okay, and this eye is having normal. So if I shine the light rays in this eye, then the pupillary response will not go to this direction due to optic neuropathy. So this pupil will not constrict and it will dilate. Okay, now if I shine the light in this eye, as this eye I told you is the normal eye, so direct response will be there. That means efferent pathway is normal in this eye. Okay, and the efferent pathway, that is the pupillary response going away from the brain stem and innervating the iris muscle. So here optic neuropathy present, but efferent pathway is away from this optic nerve. Okay, so this is why the response is seen in the other eye. Okay, if I shine the light rays in the normal eye, here efferent pathway is normal, so this will constrict, and due to this consensual response, the other eye will also constrict. Okay, so this is how it is working. Okay, so here suppose here due to this optic neuropathy, the pupil is non-reacting. That means the pupil is not at all reacting, not at all dilating. Okay, sometimes in OPD we see that the pupil is sluggish reacting or those things, but here in this case pupil is very fixed. Okay, so it can be some other example like pharmacological dilation also there. Okay, or something about trauma, or what to say, or post-operative pupils also sometimes show fixed pupil. Okay, so here if I shine the light rays on the right eye, then this eye will not show any response like constriction, dilation, nothing. And if I shine the light in the left eye, so here optic neuropathy is present, so here pupil will not constrict and dilate, it will be fixed. So this eye will also dilate because it is not getting any pupillary stimulus. And if I shine the light in this eye, here it also constrict. It means direct response is intact and consensual is not present here. That means what is that here pupillary fibers or muscles are not at all working properly. Okay, so it can be due to optic neuropathy, or it can be due to any trauma or post-operative cases. So from this also we can see that a presence of relative efferent pupillary defect is present or not. Here right eye is normal, left eye is having optic neuropathy. So this is how you will see these things. Okay, now if I tell about the grading of this RAPD, then in grade 1, when you shine the light in one eye and also compare the constriction dilation of the of one eye with the other, then in grade 1 a weak initial pupillary constriction followed by greater redilation is there. Okay, so this is grade 1. Okay, and in grade 2 you will see an initial pupillary stall followed by greater redilation. Okay, and in grade 3 an immediate pupillary dilation will be seen. Okay, and in grade 4 immediate pupillary dilation followed by 6-second illumination. There is pupillary dilation is there, that you will see. And in grade 5, that is the ultimate, where pupil is not showing, not at all constriction, only dilation is there. Okay, so you can easily find or detect grade 5 and grade 4, but to detect grade 3 to 1, okay, you need experience. Okay, you need to practice this RAPD testing regularly to make you able to understand grade 3 RAPD, grade 2 RAPD, and very experienced people only can detect grade 1 RAPD, because here only a weak initial pupillary constriction with greater redilation is there. But if the RAPD is grade 5, then you can easily detect it. Okay, so here these are the causes where you will see relative efferent pupillary defect like optic neuritis, optic nerve tumor, retinal detachment, glaucoma, orbital tumor, something like that. So here another thing I want to tell you is that if the pathology is present in the cornea or lens, you will not see any relative efferent pupillary defect. Or if the pathology is present behind lateral geniculate body, then RAPD will be not there. Okay, and because the pupillary pathway is limited from the retinal ganglion cell to before the lateral geniculate body. Okay, so if defect is present from this retinal ganglion cell to this protected nucleus area, then only you will see relative efferent pupillary defect or abnormal constriction dilation. Okay, now there are other another disorder that is seen, that is called as Addis tonic pupil. So in Addis tonic pupil, the efferent pathway is affected, but efferent pathway is normal, efferent pathway is affected. So in Addis tonic pupil, what is happening is that the ciliary ganglions are actually damaged, so that as in the beginning of my presentation, I told you that this ciliary ganglion here, from here pupillary fibers divided into two parts. Okay, some fibers go to iris and some fibers go to pupillary fiber ciliary body. Okay, so here we also know that in accommodation there is meiosis also there. Okay, three tired that we know, that accommodation, meiosis and convergence. So these are three things that happen when a person see a near object. But in case of Addis tonic pupil, the pupil is dilated for the distant object, and when the patient is seeing a near object, pupil constrict very much. Why? Because there is damage to the pupillary fibers in the ciliary ganglion. So when pupillary fiber again regrow, then sometime what happens is that the fibers actually grow more in the iris area, not in the ciliary body. So here when the patient actually so the fiber that are that's supposed to go to the ciliary body are now going to iris. Okay, so in distant the pupil is dilated. Okay, this is pupil dilated, but in near, those acting fibers for ciliary body is now acting in the iris. So here it will show you more constriction, as well as there is not uniform distribution of the pupillary fiber in the iris in Addis tonic pupil. So you will see vermiform movement. So to detect this Addis tonic pupil, what we do is that we just instill low dose of pilocarpine. So in low dose of pilocarpine, the normal looking eye will not constrict, but the pupillary the Addis tonic pupil having eye will constrict. So from that we can easily understand that yes, this is an Addis tonic pupil. Okay, so that's all friends. Thanks for tuning. Please don't forget to like my video, subscribe to my channel. I hope this video helped you to understand something more about relative efferent pupillary defect, and I hope you will start to test this RAPD regularly to each and every patient to make you able to understand different types of grading in RAPD. Okay, so thank you so much.